Hello everyone and welcome to the first of the 3 lectures in the localization of myocardial ischemia after the introduction, and we are starting with culprit in anterior STEMI. Here we are going to learn how to localize the culprit artery and culprit lesion in patients with anterior STEMI. Before we begin, the following ECG features suggest the culprit lesion in the majority of patients, but you need to know but they are not solid rules in all patients due to anatomical variation between individuals and sometimes the presence of collateral circulation in patients with pre-existing chronic coronary syndrome may make these rules not be enough to localize the culprit lesion in those patients. So this is an important tip that we need to assure before we begin. Let's remind ourselves with the coronary anatomy that we have discussed in the previous lecture. We have the left main coronary artery bifurcating into LAD and LCX. LAD give origin to the diagonal, supplying the anterolateral wall, and septa perforator supplying the interventricular septum, and the LCX give rise to the OM branch supplying the lateral wall. We have then the right coronary artery, which give rise to the colon branch and RV branch, and then it continue posteriorly in order to bifurcate into the posterolateral branch and PDA. And so, when we speak about the anterior STEMI, we speak about this region of the myocardium involving the anterior wall plus minus the lateral wall. So this wall corresponds to the anterior STEMI in case of anterior wall myocardial infarction. In 80% of patients, the LAD of course course around the apex of the LV to terminate at the diaphragmatic on the inferior surface of the LV, and so it supplies a portion of the inferior wall of the myocardium. And in 20% of patients, the LAD terminate at or before the apex, and in this case, the PDA is large enough to supply the apex of the LV. We divide the walls of the left ventricle into 3 regions: the apical segment, the mid segment, and the basal segment. And if we need to divide the left ventricle as a whole into walls, we can divide it into the anterior wall, or sometimes it's called the anterosuperior wall to differentiate it from the inferior wall. We have also the anterior septum, which involves nearly about anterior to third of the septum, and these 2 walls are supplied by the LAD. And we have the posterolateral wall, which is mainly supplied by the LCX, and we have the inferior wall, which is mainly supplied by the RCA in the majority of patients. So when we speak about anterior wall, inferior wall, lateral wall, of course these walls correspond to the left ventricle, because we have of course discussed before the RV infarction in another lecture. So here anterior wall, inferior wall correspond to the LV walls of course. So when we see a patient with anterior STEMI in his ECG, of course we think that the culprit artery is mostly the left anterior descending artery or the LAD, and when we are having coronary angiography for this patient, of course we are searching for total occlusion in the LAD as a culprit artery. Of course, we mentioned before that the diagonal branch supplies the lateral wall of the LV together with the LCX, and so sometimes when the LAD occlusion is proximal to the first diagonal, it can cause lateral wall infarction together with the anterior wall, resulting in ST elevation in the lateral leads 1 AVL, V5 and V6. So of course don't be astonished when you see that the patient with anterior STEMI is having ST elevation in 1 AVL, V5, V6. This is sometimes occur when the LAD occlusion is very proximal, that it occurs before the origin of the first diagonal. So the amount of the LV jeopardized depend of course at the site of occlusion in the LAD. This means that the LAD occlusion sometimes may lead to extensive anterior STEMI as the ST elevation evolves from V1 to V6 plus minus 1 AVL, and sometimes it may lead to just anteroseptal STEMI as the ST elevation from V1 to V4, anterolateral STEMI from V3 to V6, or even sometimes just septal infarction or septal STEMI as it produce ST elevation in V1 and V2. This depends on which site in the LAD is occluded. And lateral lead can be involved, as we mentioned before, if the LAD occlusion occurs proximal to the ostium of the diagonal, leading to ST elevation in the lateral leads. So of course, proximal versus distal LAD occlusion is very important, because proximal LAD is an independent predictor of worse outcome in patient if we compared it to distal LAD occlusion regarding increased mortality, lower ejection fraction, higher peak of cardiac biomarkers, worse scale class in the patients, higher risk of major adverse cardiac events, and recurrent MI. So of course, proximal LAD occlusion has a worse prognosis in comparison to distal LAD occlusion, and it makes sense because the amount of LV exposed to infarction here is much larger than in case of distal LAD occlusion. So remember, the more proximal the LAD occlusion, the more chest leads showing ST elevation, and the worse the prognosis of the patient. Here we can see the 6 precordial leads from V1 to V6 with their anatomical location, and we need to ask a question: which lead of them shows maximal ST elevation in case of anterior STEMI? Of course, V2 and V3 are the most ECG precordial leads to show maximal ST elevation, as lead V2 also is the most sensitive to record ST elevation and identifies a culprit lesion at the LAD. And of course, we need to remind ourselves that the cutoff point for ST elevation in V2 and V3 is different from the other ECG leads, up to 2.5 millimeters in males less than 40, up to 2 millimeters in males more than 40, and up to 1.5 millimeters in females regardless the age. Why not V1? Of course, this is a very logical question that we need to ask ourselves, because V1 is the anterior lead, but we didn't mention that it shows a maximal ST elevation. It depends on the fact that V1 records electrical activity from the right paraseptal area, which has double perfusion by septal branches from the LAD and coronal branch of the RCA. And so this explains why in patients with inferior STEMI, when they have RV infarction, it can cause ST elevation in V1 as we mentioned before, and anterior STEMI usually show ST elevation starting from V2 plus minus V1. So V1 may be involved in anterior STEMI and may be not involved in anterior STEMI. This explains why V1 may not show ST elevation in some cases of anterior STEMI due to the double perfusion and its anatomical location and the right fourth intercostal space. So V1 can show ST elevation in case of inferior STEMI with RV infarction, and in patients with anterior STEMI, when the LAD occlusion occurs proximal to the first septal perforator and the coronal branch is rudimentary, in this case the ST elevation can start from V1, as here the basal septum is mostly involved. So mostly ST elevation V1 would occur in very proximal or near ostial LAD occlusion. We need to ask another question that we have mentioned before. Can ST elevation occur directly in AVR, not reciprocal? Of course, yes, in case of infarction of the basal septum, as in case of very proximal LAD occlusion, it can lead to ST elevation AVR, because of course the basal septum receives septal branch from proximal LAD and from also the coronal branch of RCA. And as AVR is directly facing this region anatomically, of course, as we mentioned before, that it faces the basal septum, so in case of basal septal infarction, it can result in ST elevation in case of very proximal LAD occlusion. And AVL, of course, can also be involved in case of lateral wall infarction, as the LAD occlusion occurs proximal to the first diagonal. So these two leads can be involved in anterior STEMI, of course. Let's see this diagram here, which represents the 6 limb leads and the diagram of the heart. When the patient is having extensive anterior STEMI, as the LAD occlusion occurs proximal to the first septal perforator and first diagonal, here the amount of LV exposed to infarction is huge, and so the axis or the current of injury here is directed upwards toward AVL and AVR, and this explains that the patient can have ST elevation in AVL and AVR in case of proximal LAD occlusion, and they are away from the inferior leads, resulting in reciprocal depression in inferior leads. So presence of these ECG signs in anterior STEMI denotes extensive infarction and very proximal occlusion in the LAD, indicating worse prognosis. Whereas in this case, when the distal LAD occlusion occurs, here the amount of LV exposed to infarction is limited and smaller in size, and so the direction of vector here is downwards away from AVR and AVL. So they can show here isoelectric ST segment or sometimes ST depression, but there is no reciprocal depression in inferior leads as in the first example. So let's make a resume of the most powerful predictors of proximal LAD occlusion that gives you a note when you see the ECG that this patient is having a very proximal LAD occlusion at a very high risk and worse prognosis. Of course, ST elevation from V1 to V6 indicating large magnitude of infarction in the anterior wall. ST elevation AVL denoting lateral wall infarction and LAD occlusion proximal to the first diagonal. ST elevation AVR denoting basal septal infarction and LAD occlusion proximal to the first septal perforator. Reciprocal ST depression inferior leads more than 1 mm, indicating the current of injury away from the inferior leads due to severe or extensive infarction, as we have seen before. Sometimes ST depression may occur in V5, denoting here that the extensive infarction and the injury vector away from the V5 plus minus V6. Disappearance of septal Q waves in lateral lead, especially in 1 and AVL, denoting here, of course, that the current of injury is mainly towards the lateral leads, and so indicating extensive infarction. So let's learn them gradually in order to understand what does each site in the LAD occlusion produce in the ECG. When the LAD occlusion is proximal to S1 and diagonal 1, I can expect in the ECG to see ST elevation from V1 to V4 plus minus V5 and 6, ST elevation AVR and or AVL, and we understood why. Reciprocal ST depression inferior leads as the injury vector is away from them, and sometimes the patient may have acquired right bundle or left bundle branch block, because as we mentioned before, that the interventricular septum receives dual blood supply from the LAD and the PDA. Septal perforators of the LAD supply the anterior 2/3, and the PDA give also septal branch to supply the posterior 1/3. So in some cases, when the blood supply is rudimentary from the PDA, the patient can have right bundle or left bundle branch block, as we call it acute bundle branch block. When the LAD occlusion occurs distal to S1 but proximal to diagonal 1, here the basal septum is spurred, so there is no bundle branch block, of course, no ST elevation in V1, and usually no ST elevation in AVR. But still, the patient can have ST elevation AVL and reciprocal depression inferior leads plus minus AVR, as here the injury vector is away from it. When the LAD occlusion is much distal to S1 and diagonal 1, so here it is not a proximal LAD occlusion as in the first example. Here the lateral wall and base anterior septum are spurred, so no ST elevation AVL, V5 or V6, no reciprocal ST depression inferior leads or AVR, but still the patient can have ST elevation from V2 to V4, as we call it sometimes anteroseptal STEMI. There is also an anatomical variant in which the patient can have first diagonal branch arising proximal to the first septal perforator. So when the LAD occlusion in this uncommon example is distal to diagonal 1 and proximal to S1, the patient here, the lateral wall here is spurred, and so there is no ST elevation in AVL, V5 or V6, no reciprocal ST depression inferior leads or AVR, but it is proximal to S1, so ST elevation can occur in AVR plus minus V1, and the patient may develop bundle branch block. Of course, I know that it may seem to be difficult to mention them in this way that is written in books, so let's try to understand them in a different way or a practical way from the ECG itself and predict the culprit lesion together. Here the patient is having ST elevation V1, 2 and 3, and is having new right bundle or left bundle branch block with an initial Q in V1. So I can expect here that the occlusion, of course, is proximal to S1 due to presence of new bundle branch block. Let's see this example here. The patient here is having ST elevation from V1 to V5 with right bundle branch block morphology in the precordial leads, and so I expect here that the patient is having anterior STEMI with LAD occlusion proximal to S1 and diagonal 1. So here I could predict the culprit artery and the culprit lesion. So remember, acute right bundle or left bundle branch block are not common sign in anterior STEMI, as the interventricular septum receives dual blood supply, but of course when it occurs in some patients it gives us a clue that the LAD occlusion is very proximal with a worse prognosis. And once detected in ECG, of course, it is a very high risk sign. Another example, the patient is having ST elevation from V1 to V3 and also is having ST elevation in AVR. Of course, it is a high risk sign that suggests occlusion also of the LAD proximal to S1. Let's see this example here. The patient is having ST elevation from V1 to V4 and also he is having reciprocal depression in inferior leads together with ST elevation in AVR. So here I expect an anterior STEMI with LAD occlusion proximal to S1 and diagonal 1, especially when the patient is having rudimentary coronal branch resulting in the ST elevation in AVR and in V1. So in conclusion, ST elevation AVR can occur in left main equivalent and anterior STEMI with proximal or near ostial LAD occlusion, and we have mentioned this before in the lecture of ST segment in AVR. And remember, it is not a must that LAD occlusion proximal to the origin of S1 produce ST elevation in all the precordial leads. Sometimes it may only involve V1 to V4, but the presence of additional signs in limb leads gives us a clue to proximal LAD occlusion. Another example, the patient is having ST elevation in V1 to V3 with ST depression inferior leads plus minus in AVR. So here I expect to see occlusion of the LAD proximal to the diagonal 1, but mostly it is distal to the septal perforator because here there is no sign suggesting occlusion proximal to S1. So in this ECG, for example, we can see ST elevation from V1 to V6 plus 1 and AVL. So here I can see also ST depression in the inferior leads. So it is extensive anterior STEMI with tombstone appearance as the magnitude of ST elevation is heroic, and there is LAD occlusion here mostly distal to S1 but proximal to diagonal 1. So I could expect here the culprit artery and culprit lesion. Another example, ST elevation from V1 to V3 with ST elevation in AVL. So here I expect occlusion of the LAD proximal to diagonal 1 but mostly distal to S1. Let's see this example here. I can see ST elevation from V1 to V4 with ST elevation in 1 and AVL, and there is no reciprocal ST depression apart from slight ST depression in AVR. So sometimes it may appear in the inferior lead, sometimes it may appear in AVR or in both of them. So here it is a case of anterolateral STEMI as the patient here is having LAD occlusion distal to S1 and proximal to diagonal 1. So the anterior leads are involved from V1 to V4 and also in 1 and AVL. So it is anterolateral STEMI. Another example, here we can see ST elevation in V2 to V4 but with isoelectric ST segment in inferior leads. So here I suggest occlusion of the LAD distal to the first diagonal and of course distal to the first septal perforator, maybe in the mid segment or the distal segment, but here it is not proximal LAD occlusion. So for example, in this ECG, we can see ST elevation from V2 to V4 and it is sparing V1 because septal perforator is not involved and there is no additional ST elevation in other leads or any reciprocal ST depression. So I can expect anteroseptal STEMI with LAD occlusion distal to S1 and diagonal 1. Another example, here we can see ST elevation from V2 to V4 sparing V1. No any ST elevation AVR, AVL, no reciprocal ST depression. So also it is anteroseptal STEMI with LAD occlusion distal to S1 and diagonal 1. So let's see this flow chart here. When a patient is having ST elevation from V1 or starting from V2 till V5 or V6, here I can see anterior STEMI and I can predict that the culprit artery is a LAD. But where is the culprit lesion? Let's check the inferior leads at first. If there is ST depression more than 1 mm, so I can expect that the injury vector is directed away from them due to extensive anterior wall infarction, so mostly the LAD occlusion is proximal to diagonal 1. But if the ST segment is isoelectric, so the LAD occlusion is mostly distal to diagonal 1. I would also check AVL lead if there is ST elevation, so I can predict that the lateral wall here is involved in the infarction, so mostly LAD occlusion is proximal to diagonal 1. And the FST segment is isoelectric, so mostly LAD occlusion is distal to diagonal 1. I can also check AVR. If there is ST elevation in AVR, so also the injury vector is directed upward toward it due to extensive infarction. So I can expect that LAD occlusion is proximal to S1 with involvement of the basal septum. And if ST segment is isoelectric or depressed, so LAD occlusion is mostly distal to S1. So now we can say that the wider spread of reciprocal ST depression in a patient with anterior STEMI indicates a larger extent of MI and worse prognosis. So not only the extent of the ST elevation that indicates the proximal occlusion, but also the reciprocal ST depression. Its presence and its wider spread indicates larger extent of infarction. Example, when a patient is having anterior STEMI with reciprocal ST depression in inferior leads, it indicates worse prognosis than anterior STEMI without reciprocal ST depression due to more proximal occlusion in the first example. Now it's time for some unique questions that may of course come into our minds regarding the culprit, artery and lesion in patients with anterior STEMI. So let's answer them together. The first question: what about a patient with ST elevation in anterior leads but with ST elevation in inferior leads? Of course, this is not an uncommon example to be seen in our practice. Here, I suggest that the patient is having LAD occlusion, but the LAD here is wrapping around the apex to supply the infraoapical region of the LV, as we have seen that sometimes it occurs. Here, the LAD supplies both anterior wall and inferior wall with mostly non-dominant or small rudimentary right coronary artery, so it is called wraparound LAD. Is there another possibility? Yes, of course, there is another. Sometimes here the patient have a right coronary artery which is large and dominant, but here the LAD was totally occluded for a long time, that we call chronic total occlusion or TTO, and is retrogradely supplied by the dominant RCA. So when the patient develop acute occlusion of the right coronary, this would result in ST elevation in both anterior leads and inferior leads. So is ischemia at the anterior wall and the inferior wall territories. So here is an example that the patient is having ST elevation from V2 to V6, and also there is ST elevation in inferior leads. So it has a possibility of acute occlusion of LAD wrapping around the apex, acute occlusion of right coronary retrogradely filling an LAD with CTO, or the opposite, acute occlusion of LAD retrogradely filling an RCA with CTO. The second question: what about ST elevation in V1 and V2 only, without any ST elevation in other precordial leads or limb leads? There are two possibilities. The first possibility is septal branch occlusion. Sometimes they call it septal STEMI in literature. This explains why the patient is having only ST elevation in V1 and V2, and here the septum is dependent mainly on the septal perforators without other additional blood supply. And sometimes very distal LAD occlusion, distal to the most of the diagonals and septal perforator, may result in apical infarction with only ST elevation in V1 and V2. See, these are two possibilities for ST elevation only in V1 and V2. Here is an example of an ECG that the patient is having ST elevation only in V1 and V2, and so this patient, I can suspect septal branch occlusion or very distal LAD occlusion with apical infarction. So don't ignore presence of ST elevation in V1 and V2 in a patient presenting with chest pain, especially even if it is not fulfilling the full-blown criteria, because it is a start of infarction. The third question: we understood from this lecture that reciprocal ST depression in patients with anterior STEMI usually appear in the inferior leads, plus minus also in AVR, and this indicates proximal LAD occlusion. Can it appear in other ECG leads? Yes, of course. It can occur in AVR, as we mentioned, and also in V5 and V6. And this according to the orientation of the heart in relation to the ECG leads. So for example, here in this ECG examples that we have seen before, we have seen ST elevation from V1 to V4, and also in lateral lead 1 AVL with ST depression EVR, and this indicates also an occlusion mostly proximal to the first diagonal, and here the injury vector is directed away from AVR and towards the lateral wall. This explains why there is ST depression in AVR and there was no ST depression in inferior leads here. And so the occlusion is mostly distal to S1 and proximal to diagonal 1. Another example here with a patient with tombstone appearance, and the patient here is having extensive ST elevation from V1 to V6 and also 1 in AVL with ST depression in AVR, indicating also the occlusion distal to S1 and proximal to diagonal 1 with extensive ST elevation. Here is another example with a patient who is having ST elevation in V1 and V2, which may indicate, of course, septal STEMI or distal occlusion. But here there are additional ECG signs as the patient is having ST elevation also in AVR, which may indicate here that the septal branch occlusion. Here it results in infarction of the basal septum, and this explains ST elevation in V1, V2 only together with the AVR. But there is ST depression in V4, 5, and 6, and also in 1 AVL and the inferior leads. So it may be septal branch occlusion with reciprocal depression in the inferior leads, but also it may give us a clue for left main equivalent due to the presence of widespread ST depression with ST elevation in AVR and V1. The last of the unique questions. The culprit artery in anterior STEMI is mostly LAD in the majority of cases, but can it be another vessel, not the LAD? Yes, of course. In case of chronic total occlusion of LAD and it is retrogradely supplied by collaterals from LCX territory, RCA, or ramus intermedius. So in this case, occlusion of the LCX, RCA, or ramus can result in anterior STEMI, and these are the culprit arteries in this example. So here the LAD is chronic total occlusion and not the culprit artery for the infarction. And in case of large sizable diagonal or septal branch that sometimes occur in anatomical variant, and it is supplying a significant portion of the anterior wall, so the occlusion of the diagonal or the septal branch can result in anteroseptal STEMI, for example. And here the culprit is not the LAD itself, it is a branch of the LED. So remember, the culprit in anterior STEMI is almost always LAD, with few clinical exceptions like in case of pre-existing CTO of LAD or sizable branches from LED. So near the end of our lecture, any ST elevation or ST depression in a patient with chest pain gives us a clue, even if not fulfilling the criteria, whether for the diagnosis of the STEMI itself or for localizing the culprit artery and culprit lesion. So at the end, we understood today how to localize the culprit artery and culprit lesions in patients with anterior STEMI, as together with these ECG signs help us to localize the culprit lesion. And our take-home message today, ST elevation, AVL, and AVR in patients with anterior STEMI help to localize the culprit lesion in the majority of cases. And the wider the spread of reciprocal ST depression in anterior STEMI, as in inferior leads or AVR, the larger the extent of infarction. Thank you very much for watching, and wait for the culprit artery and culprit lesion in inferior STEMI and lateral STEMI.